Hello, and welcome to another excellent session of the second phase of HSR's the Health Systems Research Symposium for 2020. My name is Daniela Rodriguez, and I am your moderator today. On behalf of Health Systems Global, the symposium conference organizers and staff, and our panelists, I want to thank you for your engagement today. I'm personally quite excited for today's session. Our panelists today represent incredible diversity across countries and regions, and the presentations cover different levels of the health system, different framings for evidence, and touch on the historical choices that lead to where we are today. So today we will be talking about building capacity and leadership for evidence-informed decision-making with these excellent panelists. As I said, I'm your moderator, Daniela Rodriguez, and I'm an associate scientist in the Johns Hopkins Bloomberg School of Public Health, where I conduct health policy and systems research at the intersection of political science and public health. I'm also the outgoing chair of the thematic working group focused on translating evidence into action. It is RTWG's great pleasure to help host the session focused on building capacity and leadership for evidence-informed decision-making. For today's session, I'm going to provide a brief introduction of today's panelists and their topics, and then we will move to the presentations themselves. And after all the presentations have concluded, we'll move into a Q&A with the audience as well as a panel discussion. Please use the conference platform's tools, which I'm about to describe in a moment, to introduce yourselves and submit your questions to the panelists. So some quick tips on using the platform. First, if you have any needs for support, there's a support chat function on the top right corner of the page. For the Q&A session, we will be drawing on your questions. For the panelists, please submit your questions in the live Q&A section on the right-hand side of your screen. We also ask that you introduce yourselves in the discussion forum. As you pop it up, let us know your name, where you're from, where you're joining us today. For the best user experience, please view the session in a full screen format. Note that the sessions are recorded and should be available after the conference. And we suggest that you adjust your Zoom, your browser ratio so that you can best enjoy the session. The other thing I wanted to let you know that we're going to be starting today with 3 presentations that touch on different approaches to capacity assessment and development first. Then we will hear about examples of capacity needs, one emerging from health system reforms and another from a network of early career professionals. Let me introduce each panelist. First, we have Jorge Barreto talking to us about the ESPI project, a large-scale platform for increasing the institutional capacity for evidence-informed health policy in Brazil. Dr. Barreto is a master and doctor in public policy, and he's a researcher in public health at the Osvaldo Cruz Foundation in Brazil. He's also the associate editor of the EPOC group, part of the Cochrane International Collaboration, and he's a member of EVIPNet Global's advisory committee. Next, we will hear from Ghansham Gautam. Dr. Gautam is talking to us about strengthening local health systems in decentralized settings, experiences from an organizational approach in Nepal. He's a health economist and planning advisor working with HERD International and the Ministry of Health and Population in Nepal. Dr. Gautam is a health economist with more than a decade of experience in health systems and financing at the national and international levels. His professional experiences focus on health systems research, policy and planning, and capacity enhancement in developing countries. He's currently working for UKAID's Technical Assistance Project to the Ministry of Health and Population in Nepal, providing strategic support in the context of health sector transitions to federalism. Next, we will hear from Dr. Kulsum El-Sayed, telling us about assessment aspects of the capacity of using evidence to inform policymaking, the results of a scoping review. Dr. El-Sayed is a health policy advisor at the Ministry of Health and Population in Egypt. She's a seasoned public health professional with years of experience working with high-level policymaking with exposure to global, regional, and national levels. Dr. El-Sayed's focus is on reform programs, planning, and implementation with a special interest in health politics. She has received local and global recognition for her achievements. Next, we have Dr. Andrés Vecino Ortiz talking to us about the evolution of policy analysis in the health sector in Colombia. Dr. Vecino is an assistant scientist at the Johns Hopkins Bloomberg School of Public Health, a faculty member of the International Health Department there, and he's a health economist mainly interested on the economics of prevention and institutional economics of middle-income countries. He is also a member of the board of directors of Health Systems Global. Our final panelist is Ermel Johnson. Dr. Johnson is going to talk to us about empowering early career researchers, practitioners in getting health policy and systems research into action, the strategy of the West African Network of Emerging Leaders. Dr. Johnson is a public health physician, research assistant, and working with the West African Health Organization in Burkina Faso. Dr. Johnson is a health policy and systems researcher with a focus on evidence use in policy and practice, implementation, and reproductive health. He's a member of several networks, including the Africa Evidence Network and the West African Network of Emerging Leaders for Health Policy and Systems Research, where he leads the Generating and Translating Evidence to Policy TWG. He is currently pursuing his PhD at the African Institute for Health Policy and Health Systems at Ebonyi State University, Nigeria, where his research focuses on HPSR financing in West African countries. With that, we're now going to turn to our panel presentations. We're going to watch them all in sequence as I've presented them here, and we will see you on the other end to have a really interesting, lively, and thoughtful discussion about building capacity and leadership for evidence-informed decision-making. Thank you.
Hello, my name is Jorge Barreto. I'm a researcher in Oswaldo Cruz Foundation of Brazil, and today I represent the SP Project Coordination Group. My goal today is to share with you the overview of this Brazilian initiative for a national platform for increasing the evidence-informed health policy adoption in Brazil. Brazil has some tradition in initiatives to promote the use of evidence in a systematic and transparent way, both formulating and implementing health policies. EVIPNet Brazil, for example, is a success case as a knowledge translation platform, and EVIPNet is an important antecedent of the SPIL project. However, there are still relevant gaps to improve the use of evidence in the health policy decision-making process, either at the national or local level. In many Brazilian settings, the institutional capacity is still low in supporting the use of evidence in the policy formulation and implementation. The Evidence-Informed Health Policy Management Project, or SP project, is a long-term partnership between the Ministry of Health of Brazil and the Teaching and Research Institute of Hospital Sírio-Libanês, also including the National Councils of State and Municipal Health Secretaries. The main objective of SPIL projects is to develop the local capacities to EIPM and to qualify the management of health policy through the systematic and transparent use of scientific knowledge in decision-making process. To this, the SPIL project activities are based on educational process addressed to decision makers, supporters, and the other institutional actors, also aiming to increase the capacity to supporting evidence-informed policies, to developing knowledge translation products, and to developing and implementing action plans informed by global and local evidence on their contexts. The SP project is developed in 12 Brazilian states, including more than 400 participants, 26 facilitators, and 3 coordinators in a metrics-based implementation. I think it's important to say that the SP project has a governance structure shared with the decision levels of the national health systems, from local to national, and locally, the implementation has local committees that monitor the entire process. These governance arrangements have supported the implementation of the SP project over the years, ensured that it was sustainable and never lost its pace of implementation. The educational approach is constructivist and guided by competencies. Educational process include 5 steps. Identify problems and formulating explanations, elaborating learning questions, seeking new information, building new meanings, and evaluating process and products. The support tools for evidence-informed health policy making is guided knowledge translation products of the project, including the action plan. And the steps is 1, defining the priority problem, 2, identify options to address this problem, 3, identify barriers and implementation strategies, 4, consolidation of the evidence, and 5, organizing deliberative dialogues. And the last step is developing and implementing an action plan, including indicators to monitoring the change. In its first years of this edition of SP project, they has carried out 49 evidence briefs and deliberative dialogue policy, addressing different public health problems in the local context. Also, 49 action plans integrating global and local evidence are developed, implemented, and carefully monitored. The topics covered were defined locally, adopting shared process, so we have a good diversity on the representativeness of these products. As conclusion, I can say that the SP project is perhaps the largest national capacity building initiative for evidence-informed policy. The intermediate results are related to knowledge translation process and products, but the implementation, monitoring, the action plans are ongoing. Lessons learned show us that the approach is appropriated and that the SP groups are able to support the evidence use in their context, even though they have limitations. The next steps are very close and include an online meeting, national online meeting of the SP teams. And next, we will be able to start the next stage of this initiative. Thank you very much.
Hello everyone, I am Ghanshyam Gautam. I am presenting on strengthening the local health system in decentralized setting, experiences from an organizational capacity approach that was implemented in Nepal. Here I would like to acknowledge other contributors as well as support from DFID, Ministry of Health and Population and local governments for the implementation of this approach. However, the views expressed over here are of individuals, not of the organizations involved. To start with the context, after successful elections in 2017 in Nepal, the governance structure has shifted from a unitary system to a three-tiered federal system, where there is a federal government, 7 provincial governments, and 753 local governments. Such a new structure has sliced the health systems horizontally as well as vertically, creating a large number of management zones for the provision of health services. Alongside, the Constitution of Nepal has provisioned free access to basic health services, while the responsibility of delivering those services lie mainly with local levels. In such context, enhancing organizational capacity for ensuring the quality and continuum of care is one of the prime concerns in Nepal. The UK-funded health sector support program is supporting the federal as well as selected subnational governments in strengthening the health system. Part of that includes use of organizational capacity assessment framework for enhancement of local government's capacity to manage the delivery of basic health services. Whereas implementation of such approach at the local level was led by National Health Training Center, which is the apex body in the country in terms of human capacity enhancement within the health system. Generally, when we talk about the capacity enhancement, focus tends to be on individual skills. However, in this case, we have considered the organizational perspective for capacity enhancement. That starts with the identification of the critical areas within the health system. That was guided by the WHO building blocks, where we defined further subdomains within each building blocks to have wider spectrum for the assessment of the capacity. That was further tailored within the municipal level, meaning that given the mandates that municipality had to deliver, their outputs were defined that they wanted to achieve, and the progressive milestones were also defined to achieve those outputs. Based on that framework, capacity was assessed to identify the gaps that were existing at that time, which led to the development of action plan, which was further implemented and monitored over a period of time, aiming that government capacity will be strengthened to manage the health system. Here in this process, we bring the strength and weaknesses that exist within the organizational level together to inform the decision-making process, which further contributes in resource prioritizations that are available within the organizational setup. And during this process, policymakers, managers, as well as implementers come together and prepare the action plan for the implementation, which builds ownership and leads to the enhancement of the capacity. And in this cycle, there is a shared understanding in terms of what are the different roles and responsibilities, what are the functions to be prioritized, and what are the challenges that needs to be addressed. Accordingly, this cycle could be done again to address the remaining issues or gaps in the system. We implemented such approach in 7 local government sites in the country. They were from 7 provinces, representing metropolitan cities, sub-metropolitan city, urban and rural municipalities. We found that capacity score ranged from 20% to slightly above 50%, indicating that there was substantial capacity gaps in terms of what they wanted to achieve and to fulfill their mandates within the local context. However, it is important to note over here that these capacity scores are judged against the outputs and progressive milestones local governments themselves have set. It was done in a participatory manner, and assessment was done on self-assessment basis. In that sense, I mean, the results are not strictly comparable from one local government to another local government. When we did follow-up of the assessment after almost 1 year, we found that there were improvements almost in every front. For example, in leadership and governance, we found there was improved functionality of the management committees. Similarly, in service delivery front, there was a strengthening of the referral mechanism, particularly adherence of the protocols. Systematic approach was also followed for supportive supervision for the health staff to deliver their responsibilities and mandates. Similarly, in terms of health infrastructure, health facilities were assessed in terms of equipment gaps, and initiation was taken towards addressing those gaps. We also found that electronic logistic management information system were also established to better link the supply chain with the province and local level, also to facilitate within the municipal context. Similarly, in terms of health information, there was timely reporting of the HMS data improved. Also, we found that in terms of health financing situation was improving over time. Finally, to draw key lessons from this process, we realized that the participatory process that was adopted in the implementation contributed in building common understanding on what are the existing issues and gaps within the health system, within the municipal context, that means within the organizations that we are talking about. The process that was adopted was also self-assessment. That means the members from the same organization were engaged in assessing the capacity and also developing the action plan, which really helped in building ownership on the gaps or issues they had identified, also in terms of accountability of the action plans they had developed. Mutually agreed action plan provided the basis for prioritizing resources that was available within the municipal context, and hence to contribute in evidence-based planning process. This approach has been seen as a potential approach for the scale-up beyond the selected sites, and hence an operational manual has also been developed incorporating the lessons so far. So, I mean, this approach was relatively new in the Nepal context in public health setting, where we tried to implement, to assess the capacity of the organizations so that it could contribute in addressing the gaps that are persistent in the system, and that cycle could be repeated across the time, I mean, in terms of different cycles to address the remaining gaps. Thank you very much, and I will be happy to contribute further during the discussion if there are any queries.
Good day. I'm here to talk about my work as the capacity aspects of using evidence to inform health policy making. It's a scoping review study. My name is Said. I'm happy to be here. First, as an introduction, I will talk about the health policymaking process itself. It's an interdisciplinary process where policymakers face a lot of pressures and difficulties, competing priorities from different areas. The health policy making itself, it's an act of a policy network that entails different actors. And each player in this network has different agendas to achieve and different capacity to influence the process itself and other players in the policy networks. And in this network, it is not a fixed structure. We cannot predict its structure, and it is different from policy issue to another, from time to time for the same policy issue. And among all these difficulties and challenges comes the term or the process of health-related evidence-informed policymaking. So what is this? It is a tool that helps policymakers to make a well-informed decisions about policies, programs, and projects. How? By putting the best available scientific evidence at the heart of the policymaking process and the implementation of the resulted policy afterwards. So what was the objective of my work is, the objective was to map the different capacity aspects needed for the use of evidence into health policymaking in relevant literature. And the result of this work is anticipated to contribute to the development of a more robust and comprehensive health-related evidence-informed policymaking assessment tool. So how it was conducted, I conducted a scoping review. The data collection step ended by 123 studies. The data analysis was divided into 2 steps. The first one ended by identifying and mapping the different capacity aspects needed for the use of evidence into policymaking. The second step was to use the result of the first step to map the different assessment tools as reported in relevant literature. So the first deliverable, as you can see, was to map the different capacity aspects as identified and reviewed and studied in the relevant literature. In the left column, you can find the main categories, which are actors, content, context, inputs, processes, and outputs. The following column represents the different types or subcategories of each aspect. Then the following column represents the set of factors that affect each of these capacity aspects and their subtypes. And finally, the final column represents or shows how these different capacity aspects are affecting each other. So for example, if we talk about actors, we can find subdivisions of individuals such as policymakers, decision-making organizations such as ministries of health, evidence generation organizations like academia, research institutes, international organizations, and knowledge providers. Then we can find for each subcategory different impact or different affecting factors. For example, background of the policymakers or the infrastructure of the decision-making organization, the politics, staff capacity, and so on. And these different subdivisions or subcapacities, sub-aspects are affecting the other capacity aspects in different ways. So it is affecting how the evidence is being selected, how it is being employed in the policymaking process afterwards. The second deliverable was to use the different identified capacity aspects to map the different assessment tools that were reported in relevant literature. So in the left column, you can find the set of tools, the measurement tools that I found in the relevant literature. And the gray colors or the gray boxes here represent the coverage areas. And the white boxes represent the areas that were having less attention or less studies in the assessment tools. In this chart, we can find the different or the disproportionate studies for different capacity aspects. So for our example, in the actors, we can find that we're higher attention to some subcategories, but for other subcategories, such as policy analysts and international organizations, there were less attention, if any. And the same, of course, for other capacity aspects. In the left side of this slide, we can find collectively or comparatively how the different capacity aspects were studied in the relevant literature. We can find higher attention given for the inputs and actors. However, other capacity aspects like content and outputs, such as the policy briefs, have or had less attention in the assessment tools. In the right side of this slide, I compared between 3 different tools, assessment tools, that were having higher coverage in studying the different capacity aspects needed for the use of evidence into policymaking. And also they have the highest coverage, but we can see that this coverage was not comprehensive. We can find some zeros here and there, which means that some capacity aspects were neglected in this tool. So to conclude, the result of this work is to have a map of the different assessment tools that assess the different capacity aspects needed for the use of evidence into policymaking. And we could identify the different gaps or the different areas that need more attention and more study. So the next step is to develop a more comprehensive assessment tool and to use this tool to analyze the institutional capacity aspect and to use the result of this analysis to develop the capacity of such institutes. And of course, the overarching goal is to develop better health decisions. Thank you.
Hi, everyone. My name is Andres Vecino, and we're going to talk today about the evolution of policy analysis in the health sector in Colombia. This is a work that was done along with Stephanie Puerto, Diego Lucumí, and Janet Mosquera. This is a part of a work done for the chapter of a book, the Policy Analysis in Colombia. And in this study, we discussed the development of policy analysis studies in the Colombian health sector since the health reform in 1993, as well as the heterogeneity of such development across different health sector institutions in the country. We assessed the development of policy analysis in the health sector at the national, the departmental, and the municipal level in the country, and we assessed precisely the heterogeneity across those levels. For this study, we conducted an extensive document and report review, and we conducted also interviews with one female and 5 males who were current or former officials from the Ministry of Health and related agencies, as well as former officials from the Health Secretariat of Bogota, that represents the departmental and municipal level. The method we used, the framework we used was the policy cycle process, and on each of these notes, we identified the specific issues related to the policy analysis process in the health sector and how that has evolved over time. So very quickly to our results, on agenda setting, we found that the national health sector institutions play a critical role in steering national health policy. However, we found a large fragmentation of the different units within the Ministry of Health and other health sector institutions, leading them to work in silos, creating inefficiencies, gaps, and redundancies on key issues. We found that these institutions also focus too much on day-to-day crisis management rather than on long-term strategic planning. And that this has an issue that has affected the capacity of these health sector institutions to set strategic agendas. In the last around 10 to 15 years, we found that there has been a great strengthening of their technical units in the national level health sector institutions, which has increased their ability to conduct policy analysis. However, 2 main issues remain in terms of human resources. One of them is high turnover rates among technical personnel, and the other one are general issues that are common to other government employment factors, such as inflexibility in terms of hiring and firing employees, and difficult performance measurement, as well as low salaries and administrative barriers. In terms of leadership, we found a marked weakness of the Ministry of Health to champion multisectoral issues that affect health. even though in recent years this ministry has been key in leading the debate on intersectoral issues such as taxation, drug pricing, or illicit drug policy. This is not an institutionalized role, and traditionally the health sector, in particular the Ministry of Health, has had not much a role in terms of champion multisectoral issues in the country. We found also as an important landmark the development of the National Public Health Council. However, this council has not yet been producing the results expected when it was created. We also found that one key issue was on decentralization and policy adoption, in the sense that when the decentralization of public health functions in the 90s were implemented, they were without the underlying requirements to support local health governance from both a financial and a technical perspective. This was concurrent to a financial crisis, which led to the lack of construction of capabilities at the local level. We also found that this led to hospitals to take the role of public health functions at the local level. But these institutions, these hospitals were not prepared to have that role, and for that reason, public health functions at the local level were not appropriately implemented. We found that in 2007, the National Public Health Plan was established for the first time, and in 2012, the Public Health Plan for the decade was also established. It was innovative in the sense that it was a bottom-up approach. However, it lacked strong internal advocates within the different institutions, and its implementation has been rather poor. This implied that when the public health interventions were taken to a local level, there was no much ownership or uptake of the local data, and therefore evidence-based policy at the local level has not been importantly observed. In terms of data sources for monitoring and evaluation for policy, we found that Colombia has a lot of data sources, which is of course a great news. However, these data sources are highly fragmented. Some often are not accessible, and almost none of them are longitudinal. So these are key aspects that we found were important in order to improve data collection, and therefore the policy analysis that is derived from that data analysis. In terms of technical capacity, particularly at the local level, we found that the supply of skills is low. Many public health practitioners don't have any training on public health or similar fields. Legacy systems in public health programs seem to be important, and we found in general low technical capacity at the local level in terms of public health functions. On the demand of skills, we found also political capture of health sector agencies, which has also been a bottleneck on increasing technical capacity at the local level. So, in conclusion, we found a marked evolution of the policy analysis capabilities in the national level institutions. The lack of an institutionalized and binding participation of the health sector in multi-sectoral discussions has worsened the role that non-government actors have in shaping health policy. Training of public health and healthcare practitioners often lacks training on many public health functions. And finally, policy analysis in these institutions need to be strengthened to improve population health and reduce its associated costs. Thank you very much for your attention.
Hi, everyone. Thank you for joining this session. I'm Ermel Johnson, public health physician, based in Bobo-Dioulasso in Burkina Faso, West Africa. I'm one member and leading the thematic working group, generating and translating evidence into policy. I'm presenting this work on behalf of all the team who contributed. My presentation is about empowering early career researchers and practitioners who translate health policy and system research into action, the strategy of the West African Network of Emerging Leaders, FANEP. As a background, we can say that evidence used in policymaking and practice is still at infant stage in most of sub-Saharan countries, including the 15 countries of the Economic Community of West African States, ECOWAS. Health system research contributes to strengthening health systems through the production of evidence for use in policymaking and practice. The West African Network of Emerging Leaders for Health Policy and System Research was created in 2015 in Accra, Ghana, with the aim to create a critical mass of actors to influence evidence use in health policy and practice in West Africa. This work reports the experience of designing knowledge transfer strategies at the network level by health policy and system research actors. As a method, we took the opportunity of the 5th Scientific Biannual Conference of African Health Economic Association to hold an organized session. About 30 members and non-members attended the session, which lasts 90 minutes. Notes of the meetings and reports were used to compile information and analyze. 2 co-creation approaches were used for this work: case study presentations and group discussion. 3 case study was presented, which was followed by a panel discussions on 3 questions, which is how to transfer evidence presented into policy and actions, which knowledge transfer strategies can be used by WANEL members to improve maternal and child health evidence in West Africa, and what capacity are needed to build, which capacity are needed to implement these interventions. As a result, our work allows us to identify the key knowledge transfer strategies and intervention, as well as the skills and capacity required for WANEL members. Concerning the knowledge transfer strategies, it is important to map all stakeholders, both at country and regional levels. This also involves forums and platforms where the different stakeholders meet to take decisions and formulate policies. Taking into account the specificity of our region, it is important to consider cultural consideration to reduce resistance, and similarly, the evidence must be presented to help the problem of decision maker and practitioner. And doing so, they are more willing to use the evidence. For each of these strategies identified, several interventions can be carried out for each of targeted users. In addition to the usual intervention, it has proposed the following intervention: collaboration with policymakers, community outreach for behavior change, provide evidence to civil society organizations as advocacy tool, and present evidence in more attractive format. The success of these actions required capacity and skills. We should point out that WANEL members are mostly early career researchers and practitioners who are not necessarily equipped for this. As a result, the following capacity were identified to equip WANEL members: effective presentation of evidence, advocacy and lobbying, communication, stakeholder mapping and engagement, leadership. that WANEL members will be able to identify the key area of intervention and capacity needed to influence health policy. There is a need for capacity building to ensure effective and successful implementation of these interventions. This can be done through a regional knowledge translation capacity building program, taking into account the diverse background of the members. The funding of this work contributed to develop the intervention plan of the thematic working group generating and translating evidence into policy. We are at the end of our presentation, and we thank you for your kind attention.
Thank you so much for these excellent presentations. I'm going to invite all of the panelists to please turn on their video and their audio to join us for the question and answer period and discussion. For those of you watching at home, we recognize that not everybody has the bandwidth to be able to sustain video as much as possible. So we are going to have everyone on audio and then video as much as we can. So first, I want to say thank you to the panelists. What an excellent set of presentations. A lot of diversity, as I said in the beginning, focusing on different levels of the health system, lots of different methodological approaches. So very exciting. I'm going to start first with some questions coming from the audience. George, there's a question from Hoda Khaled Hassan asking, what were the governance arrangements that helped ESPI in Brazil? Can you talk to us a little bit about that?
Sure, thank you, Daniela. First, I would like to present my congratulations for my colleagues of panel. Very interesting presentations. Well, ESPI is a metrics-based project that have 3 editions in Brazil. We have 6 years developing this project, and we have a national level, national group that is include the Ministry of Health, of course, the Syro-Lebanese Institute of Research and Learning, and we include the representatives of the local level, is the National Council of Municipal Secretaries of Health, and the regional level, the state secretaries of health are included with a national council too. So this national arrangement is to decide in general level, but we have similar structure in local level. We have committees that seeking entire the process to decide in local level, for example, the priorities. So we have a prioritization process. It is very participative that includes not just only research, but we include also civil society, organized civil society groups and representatives, and especially technicians and decision makers, local level. It's very interesting because we have not a vertical program that we offer tools and issues to people produce new evidence synthesis and to organize deliberative dialogue, but the process is completely participative. I think that's a strong point of this project. It's very superficial what I'm saying, but I think we will have nearly publication describing these arrangements, and will be a pleasure to share with you. Thanks.
Great, excellent. Thank you, George. So a question for, I think, all the panelists or anyone who wants to chime in, since this is an evolving area. We have a question from Yodi Mahendradatta. Apologies, Jody, if I didn't say your last name fully appropriately. His question is, how do you build capacity to navigate the body of evidence for COVID-19, which is growing extensively, evolving rapidly, and often conflicting? And so I would welcome your reflections. I know that some of you sort of sit in a very sort of researcher specific role. Others of you are actually working in government. Others are working in a sort of more of a middle space. Any reflections, both in terms of how maybe folks at the highest levels down to the lowest levels are navigating these issues. And the floor is open.
Just to start, the discussion, maybe other colleagues can contribute. So this is quite evolving areas, and there is limited knowledge in terms of what should be done and what is the good way to do. And to take the example of Nepal, we have a 3-layer of government. I don't know whether layer is the right term. Federal government, provincial government, and local governments. After the COVID, this came as a pandemic, and then it was, of course, responsibility of each of the governments. And federal government was heavily engaged in preparing all these documents, guidelines, and in local levels, we are very much involved in managing the entry points, like a sanitation and public behavior management related activities. And whatever they were learning and whatever challenges they were facing, they were feeding back to the provincial level and the federal level. That is how on federal level kept on changing any procedures and guidelines as needed. So of course, some of the things, if we see retrospectively, then we might feel that, okay, that was probably not the best way we started, but still that is how they kept on changing. And we have like a geographically different setup. Some are very crowded with a heavy population, some are quite urban, rural setting. So it was not all over the country at the same time. When the incidents have, cases were seen in some of the areas, then preparation was going on in another areas. But from the clinical side, I can't say much, but from the overall system and management side, I think we also had time to get prepared when it just hit the country in some parts, and we still had time to manage for the other parts.
Thank you, Ghanshyam. Any other reactions?
Yeah, maybe I have. Oh, please go ahead, Andrew.
Please go ahead, Gautam, please.
Okay, I'm not answering the question, but maybe I have a comment, or maybe raising another question for our discussion or our thinking, is to just focus our discussion on this topic, is how different is building a body that focus on evidence-based policymaking related to COVID is different from other topics or other policies. In what area, in what measures, in what context? So maybe we can focus in answering this question so we can answer your question, Yudi. Thank you.
Yeah, that's an interesting reflection on Kulsum, because I think there is there is a tension between is COVID that much different, or how we build capacity for assessing evidence and internalizing it and putting it in policies, is that different than what we do for other things? Thank you for raising that. Andres, you were going to say?
Yeah, what I would say is that actually, based on the study that we presented here, we in Colombia we saw this division between the high capacity that the national government had and the lower capacity that the local levels had. And what we found is actually that is also reflected in the COVID response. So while the national level is way more capable, has better information systems, and is promoting, for example, contact tracing, some local level health departments are not or willing or able to do this. So what I would say is that it's a difficult question, but perhaps what I would say is this is one more reason to start thinking how we can actually build capacity in preparing local health systems in view of the next pandemic, and as Uncle Tom said, many other health issues that we that can be addressed at that level too.
Yeah, thank you. Any other reactions?
Maybe I have one or two comments. I think it's a very interesting question, and in our experience in Brazil, we have everybody trying to collect and synthesize evidence in a fast way, like a 100 meters ride. And after all, we understand we have a lot of duplication and people doing the same thing. And sometimes we have not the evidence in the primary level, and is quite confused to provide clear message for the people to support the collective deliberation and the government decision, and of course, our individual decision. We all are trying to identify, to understand the evidence that is in the first page of the paper and the journals, everything. And we have, another hand, we have the problem, maybe COVID promote a different phenomenon that is not about evidence, is about beliefs and everything in a political way. It's very, very complicated. It's a very, very complicated context. But I think the most important is provide a clear, with transparency and systematic way to identify useful subsides, and the people can use that in a useful manner to take the decisions. And sometimes the governments have themselves on their ways to identify evidence to support their decisions, and our mission is to identify the fails and the questions to share with the people, to have a good discussion about effects and interventions, and especially gaps. I think that's a very important question related with COVID. Thanks.
Yeah, thank you, George. Ermel, I was wondering if you could if you could share a little bit with us about how, we've been talking about sort of how do governments respond, higher level, lower level, the politics of this all, but you're part of a network. You are presenting today about these emerging leaders, these, I'm going to assume, young, energetic, folks that are entering health policy and systems research and really looking to play this role. And have you heard any reflections from them about how the COVID crisis has maybe supported their role as a knowledge broker, or maybe made it more difficult? How have they been affected, these emerging folks, by the COVID response as it relates to bringing evidence into decision making?
Well, thank you, Daniela. I think the first wave of COVID in West Africa has, everywhere in the world, was very difficult, in terms of anxiety, So actually, most of the thing was how to reimagine work. What we people know as normal is no longer normal. You're supposed to reinvent what you used to do. And in this context, providing evidence, generating evidence, and trying to reach the decision makers, you need to find another way. And for the countries, the sub-region, most of them establish committees who were linked directly to the top management, who is the president. So it's actually difficult for this kind of level as our own to reach this level. But the good thing is that there was a lot of online forum where we can attend, share our thoughts, what we are reading. In fact, as the person who asked the question said, there are a lot of evidence who are, very evaluating, who are contradicting, who contradict what others are saying. But yeah, everybody say this is what we get today. This is what we get today. So even the only fact to share the latest evidence available on journal or coming from fieldwork is also a kind of contributing from our network. And we're still thinking how to see a better collaboration with established organizations, NGOs who are working in community or in health facility, to see how we can support them in, getting this evidence to improve their work.
Excellent. So I wanted to turn a question, just sort of shift gears a little bit and ask about something a little bit different. I think not only in our space around evidence, but I think in health policy and systems research more broadly, there's often a tension about how we assess capacity and whether assessing capacity objectively, in quotation marks, where you sort of present a problem or sort of do a grading or something like that, or you observe someone, that's more objective than self-assessment, where a person may have bring in their own biases in terms of how they think about things. But I would be curious to hear your reflections on this tension between sort of an objective external assessment and a self-assessment, because you know, we have Kulsum talking about all these different capacity assessments that she looked at in her scoping review. But then we also have examples from several of you about people self-assessing their needs and recognizing what it is that they think that they are missing, that they need building. And in particular, Ghanshyam's example from Nepal, that being the basis by which you get buy-in for people to actually work on their capacity needs. So I'm wondering if you, so this is a question for the whole panel about reflections on that and thoughts about, you know, about that tension and where you think it is best to use a sort of that objective external assessment and then a more self-assessment that maybe is going to get you a different response. So the floor is open.
Okay, maybe I start with. So you rightly pointed out, Daniel. I mean, there are two perspectives of the assessments, and I think these have their own objectives, and they might one cannot replace the other. That is what I think. I mean, in terms of like objectively having this assessment, I have usually done through the external actors. I mean, when we need more like a scenario at the national level, at the certain like a district level, or more like a comparable scenario, then we need a common methodology, common approach, and that gives more like a comparative figure. When we do more like a self-assessment, that gives more accountability for the actors who are assessing themselves. And that may not necessarily be comparable strictly from one to another, because they are using their own perspective, at least in the assessment. Even if methodology is same, we get different perspective in the assessment. But in terms of accountability, I think this self-assessments, engaging themselves in the process, that helps to address the gaps that they have seen. And in the self-assessment process as such also, who are involved, that's important, whether managers, implementers, and also sometimes like political or influencing individuals from the society. If they are involved together, then really, I mean, it gets into the topic, really tries to dig into the issues and problem rather than there is any objective criteria for the assessment, and that gets accumulated at the national level. For comparative and over setting the baseline over years, objectively set criteria are better, of course, but to make one particular organization accountable and progressively monitor their own progress over the time of this self-assessment might work better. That is what I felt. So I see complementarity between these two types of assessments.
Great. Thank you, Ghanshyam.
Yeah, so I would say, Daniela, that I mean, I don't necessarily think that it needs to be attention. It can also be seen longitudinally, and perhaps there's different phases in which one can have more role than the other. And I'm saying this because in this study, actually, what we found is that when the public health plan for the decade was being created, actually, there was some level of self-assessment from different regions, assessing their needs and giving feedback to the plan. And that worked pretty well. But then the plan determined that local health departments needed to create this health situation analysis, which is by definition a self-assessment plan of your current health situation and your plans to tackle these issues. And what you see is that the quality of this is really different. and sometimes some of these local health departments actually don't have the capacity to do them. They subcontract others to do this. There's no real ownership in some specific local health departments. So there you see the variety of how differences in capacity actually can impact this type of self-assessment. So what I would say is perhaps this doesn't necessarily need to be attention. If you look at it as in the long term and in a way that you can, in some places, try a more vertical approach, but then a building capacity towards a more horizontal approach over time.
Okay, thanks, Andres.
I just would like to share my experience with institutional capacity assessment. For me, in my experience, definitely we should combine approach to identify institutional capacity in the evidence use. Recently, we published a paper with results of an assessment for Brazil of the EVIPNet Brazil groups, and we use an acknowledged tool is called Research for You from the Canadian Institute for Health, Public Health, I think, and our results combined objective and directly aimed to identify gaps or lacks in terms of institutional support, but he used qualitative sources to identify how we can categorize different barriers to achieve best performance in terms of institutional. On the other hand, we have a need to include institutional and individual view to identify, for example, if you have the resources to support the access for evidence, but the people don't have capacity to read in English, for example. And this paper show a good experience with national assessment. Thanks.
So maybe I agree with my colleagues. They are not the same. They are different tools for assessment, and we need both to have the 360 degrees of evaluation of the institutions. We can't replace one by another, and they complement each other in a way, and both will be used for the further developing the practice and the system for evidence-informed policymaking. Thank you.
The question, your question brings to my mind another question. Why are we doing assessment at first? For me, the ultimate target should be, is it possible to reach or to get impact after the intervention that we want to do? So even it is objective or non-objective assessment, whatever tool is used for this assessment, I think the ultimate view should be, is this capacity building is giving people or giving the institution capacity, the real capacity to do something, teaching something and getting the capacity, or is different actually. If I was take the example of Wanea, we have different background, journalists, sociologists, medical doctors, we even have interpreters who are really keen to be member of this network, and they are. The thing is, I will not give the same capacity building in getting evidence to policy for a journalist as an interpreter. Everybody has his own role. So it is in the chain that we'll see what this person needs and how to help him to get there. Actually, we are working in our network to do a kind of need assessment for the next level, to develop a framework for the network, how we can really fit in people the members need, because each member is in one institution actually. Either it is an academic institution or a professional institution, and around the world, and the priorities are different. We are just we are actually we have a common geographic zone. So we want all to contribute to really make the health system and policy research works in the sub-region. So for that, we are actually thinking to find a kind of incentive assessment. Okay. Last week, we even got a testimony from one member who is from Nigeria, Ada, who just shared a snapshot of one of her blog that she made on accident in Lagos, who is actually used by University of Washington Seattle for their courses. So this actually is a kind of a good impact that we can say, okay, one member of our network made it. So to say that at the end that we need to assess, yes, but we really need to put people in real condition, give their tasks, and see the needs to achieve the tasks that we want them to do, and find even it is a kind of mentoring or coaching to give them the capacity to read them. Yeah.
So what you've raised, Ermel, I mean, part of it is, right, part of our focus on the session is about capacity, but I think the point you're raising about incentives is a really important one. The extent to which, these capacity assessments that we do, and Kulsum, I'm coming to you next to talk about your scoping review, but to what extent are these assessments that we're doing looking at the incentives of different people in the different actors in the system to find relevant evidence, to synthesize it in a way that's accessible? Are people more incentivized to write or read a blog than they are to look at a policy brief? If you're a policymaker that is incentivized by getting reelected, you may be more interested in building a hospital rather than providing a nurse. So those kinds of things. And I think you're absolutely right that that's critical to that linkage between evidence then actually connecting to policymaking. So Kulsum, one of the things that was striking to me about your findings is that when you look at all these capacity assessments we have about using evidence in policymaking, there's a lot of focus on actors and not on a lot of other things. And I'm wondering if you can, if that was surprising to you, where do you think that we're, just because we're not studying maybe content or we're not looking in these assessments at outputs and stuff like that, is that a real gap? And how do we as a field try to fill it?
Yes, thank you, Daniela. Actually, was surprising to me is that different types of actors were neglected at all, like the role of policy analyst and advisor. So regardless that we have a lot of studies that are studying actors, but what about the people around the boss, around the policymakers? That was neglected in almost all of the studies or the assessment tools that I have screened. So this was surprising to me, but not surprising because of the context of what I have already experienced in my work, but that it was a universal problem or a universal gap. So I know about it from my practice in my context, but what was surprising that it is the same problem everywhere. So also what you mentioned about the content, and we are overlooking the content itself. Maybe we are focusing for the policy making from the political aspect. So we still believe that the health policy making is an individual decision, not institutional or maybe not a systematic decision. That was the conclusion, the main conclusion, that we don't look into the content itself carefully enough. I won't generalize the rule, but I would say it wasn't comprehensively being looked or being studied in the assessment rules. That's one thing. The other thing that we usually neglect other areas like having the international agencies as a knowledge broker. That was very surprising to me. What about the role for WHO, for example? How they are making themselves a knowledge broker for the Ministry of Health. That was neglected in the studies. I didn't see much literature about this topic. So I think there are a lot of gaps to fulfill. And I think this is the first step to make more comprehensive assessment tool based on local aspects, although we should have the contextual factors into consideration in developing the comprehensive tool to assess the institutions, the local institutions.
Great, thank you. So George, one of the things that I was wondering as I was looking at your presentation, and it connects to what Kulsum was saying, is for your network, how much of the evidence that was being synthesized for these local issues and questions, how much of it was Brazilian evidence, how much of it was maybe from the region or from external to the region, and how did that affect the uptake?
Yeah, first we need to understand the Brazilian health system. We have a multi-level health system. We have decision-making local level, at national level. We have vertical policies and we have local policies. So in Brazil, we have a lot of experience in local level. The first VIPNet group in the world in local level was developed in Brazil, and after this, the Minister of Health adopted as a strategy to identify people in government institutions or academic institutions, social organization institutions that would like to take part of VIPNet Brazil. Today you have 15 people, groups of different people with different profile to develop this kind of products, evidence synthesis, rapid reviews, and deliberative dialogues, and the educational activities to develop local capacities to understand the process of use of evidence. I think in terms of assessment, the most important is the purpose of the evaluation. Evaluation for us is to identify needs for improvement of the planning and action process to include evidence in a systematic and transparent way. Yeah, Brazil is very complex, and the VIPNet have these arrangements and could be complex to understand, but actually we have different levels of our network of evidence from policymaking. Thanks.
Right. So I wanted to open the floor in case the panelists have questions for each other as you're listening to what's going on in different places. Are you getting ideas, something you might want to try in your own context or something, or things you might want to avoid, or just any questions for each other? The floor is open.
So shall I?
Go ahead.
Yeah, okay. To Andres from Colombia, I mean, your experience, just to know, you said that when country moved to more like a decentralized setting, their capacity was not up to the level, and that created challenges. Of course, sometimes we could also buy the capacities. I mean, of course, not the typical, it's not that easy, but sometimes some level of capacity which can buy. So that means we need fund. So we need to match the fund with the like a situation and the capacity to deliver the services. So how the funding was arranged from the federal or to the local level, I mean, in decentralized setting, and whether it has changed over time fundamentally?
Yeah, no, that's a great question, Gansham. So what happened at the moment in which the country decided to decentralize was that there was a profound economic crisis, also security crisis, and this didn't actually only apply to the health sector. It also applied to the education sector and other sectors that decentralized. So what they did was to, because there was no capacity in the local level, they put in charge the hospitals to do all sort of public health and other type of work at the local level, and they were not in capability to do that. Actually, at the time, hospitals were facing also an important financial crisis because supply subsidies were stopped and were being changed to demand subsidies. So that made it really difficult and actually reduced local health capacity at the time. And but I think that the country has started to learn how to cope with this. So how it works is that some there's a specific amount of the national resources that are routed to.
Sorry, Andres.
Yeah.
Sorry, Andres. We have 10 seconds left. I'm really sorry. There's been a there's been a Twitter chat going on, so make sure to drop your answers and questions in there. Please join our TWG if you're interested, and we will, a proposal is being put together for renewal. So thank you so much for everyone. And I thank you so much for an excellent session. We really appreciate you coming here today. As you are finishing up today, please click on the upper left-hand button on your screen to go back to the timeline for the end of the session. Thank you.
Thank you, Daniela.
Thank you, Daniela,
all
for facilitation.
Thank you.
Thank you, everyone.
Thank
Nice
you.
to meet you.
Bye.